So welcome everyone for the grand rounds of ENACT. So this is the month of April grand rounds. And today I'm very happy to introduce Hossein Estiri. He's going to be talking about precision phenotyping in ENACT for curated cohorts of unexplained chronic conditions. So just to give you a brief background on ENACT, ENACT expands on the original project, which was called ACT, which was set up for accrual for clinical trials. And now ENACT enables EHR-based research on any disease or condition across 140 plus million patients. And this is a consortium which is consisting of NCATS, CTSA hubs, and it's funded by NCATS. And ENACT is available to all researchers at the participating CTSA institutions. So this particular grand rounds that we started is a new one. This is the second one we are having. It's a monthly seminar series, which is hosted by the ENACT network. And we are primarily focusing on leveraging real-world data for real-world evidence to advance translational science. And so we'll be covering a whole slew of topics during this series, including synthetic data sets, using EHR for cohort discovery, applying AI and machine learning, as well as clinical decision support and next-gen trial platforms. And this grand rounds is open to all the CTSA consortium members as well as non-CTSA investigators. And though we have been doing presentations so far, we'll also have in the future panels and networking events. So just to give a brief overview of the session, I'm doing the introduction right now. This will be followed by our speaker who will do the presentation. We'll have Q&As and finally some closing remarks. But as the presentation goes on, please feel free to enter your questions in the Zoom chat, and we will address them at the end of the presentation. So the learning objectives for this particular session is to understand the limitations of traditional computational phenotyping and why complex heterogeneous conditions require more adaptive approaches. And we know that ENACT, one of the primary focus on ENACT using the Shrine platform is for traditional computational phenotyping. So in this, we're going to see more complex and adaptive approaches. Hossein will explain the concept of precision phenotyping and how high parameter models enable individualized real-world cohort definitions, and identify key opportunities to scale precision phenotyping frameworks across distributed networks like ENACT to accelerate clinical discovery and trial recruitment. So I'm very happy to introduce Dr. Hossein Estiri, who is an associate professor of medicine at Harvard Medical School. He's associated with the Mass General Hospital, where he leads the Clinical Augmented Intelligence Group, or CLAI. He also serves as the head of AI research at the Center for AI and Biomedical Informatics of the Learning Health System at Mass General Brigham. So his research is at the intersection of biomedical informatics, machine learning, and population health, with a particular focus on modeling complex phenotypes from EHRs. And his work aims to advance precision medicine by developing computational frameworks that uncover nuanced patterns in clinical data to enable more accurate phenotyping and improve cohort discovery for translational research and clinical trials. And then I'll be moderating the session. So I am Shyam Visveshwaran. I'm a professor and vice chair of clinical informatics in the Department of Biomedical Informatics at the University of Pittsburgh. I'm one of the MPIs of the ENACT network, and I lead a Center for Clinical AI here at the Biomedical Informatics Department. Okay, so with that, I'm going to hand it over to Hossein to give his talk.
Thank you, Shyam. Okay, so let me start with, most of you know about these things, but just to overview that, you know that today we have more patient data than ever before. Most of this data is scattered across hospitals and health systems and networks like ENACT. But the real question isn't how much data we have, it's about how we use this data. Standard methods so far have served us well with leveraging patient data for simple diseases. But for complex and chronic, poorly understood conditions like long COVID, autoimmune disorders, and beyond, we need new approaches. What I describe here as precision phenotyping gives us one solution. It's about moving beyond rigid rules to create adaptive, high-fidelity models that can capture the true variability of disease in the real world. And today I'll show how through new models and smart algorithms and real-world deployment, we can build the next generation of precision research cohorts to accelerate clinical discovery. Let me start with the question that basically derives this presentation. And the question is, what does it take to find the right patient at the right time for diseases we barely understand? We all know that drug development is a long and tough process. Thousands of compounds are tested, but at the end of the day, only one makes it through the FDA approval. And one of the biggest hurdles is clinical trial recruitment. As we move through phase 1, 2, and 3, the number of patients needed for these drug development skyrockets. And for complex and poorly understood diseases, it's even tougher to identify patients. Without clear biomarkers, just figuring out who qualifies can slow studies to a crawl. This is where I think precision phenotyping can contribute. By using smarter, individualized models, we can find the right patients faster, build better cohorts, and truly reflect the real-world complexities we see in our clinics. It's not just about speed, it's about doing better science and getting better results for patients who need it most. So let me talk about the challenges of recruitment for clinical studies. You know that not all diseases are created equal. Some conditions like ME/CSF, for example, are incredibly tough to pin down. There's no objective biomarkers. There are highly variable symptoms. Defining who actually qualifies for trial becomes a real challenge. Then if you add the temporal complexity to the complex diseases, to diseases that shift and evolve over time. For example, think about MS, where patients cycle through relapses and remissions, or Parkinson's disease, where early motor symptoms give way to cognitive declines years later. And then we have long COVID, no universally accepted definition, symptoms that change patient to patients, and the pathophysiology we are only beginning to understand. Now imagine trying, for example, to test a new therapy for long COVID-related anosmia. How are you going to find the patients to run the clinical trials? Because, as you know, without a clear, precise definition, finding eligible patients becomes incredibly difficult. This is exactly the kind of challenge that led us to try to develop precision phenotyping, which aims to match the right patients to the right studies, even with diseases, when disease itself is messy and evolving. Okay, so given the prevalence of real-world data, especially EHRs, we now have an incredible opportunity to leverage these data to identify and build clinical cohorts in ways we never could before. Phenotyping in informatics is a process of observing and measuring an organism's physical and biochemical traits known as phenotypes. These traits can include morphology, development, biochemical, or other properties, or products of other properties. In electronic phenotyping is now defining clinical conditions across large patient population using messy real-world data that is increasingly available. What EHR gives us is a scale, but it also brings a lot of challenges most of you are familiar with, including missing information, variable quality, inconsistent formats and standards. To make it useful, we have to apply smart inclusion and exclusion criteria to fine-tune specificity and sensitivity. In standard EHR phenotyping, there's two main approaches, the rule-based phenotyping, and then there is the probabilistic phenotyping. In the rule-based phenotyping, basically an expert follows predefined clinical logic, trying to add exclusion and inclusion criteria. A lot of models developed for example, within the eMERGE consortium use rule-based phenotyping. Probabilistic phenotyping basically uses a computational or machine learning method to capture more nuanced, complex patterns that traditional rules might miss, or it's hard to basically build a rule-based model for. Both strategies have their strengths, and depending on the complexity of the condition, the quality of data, and the research goals, the right choice basically can turn messy real-world data into powerful real-world insight. Now, some clinical phenotypes are more straightforward. Examples are diabetes or hypertension. We have clear diagnostic thresholds for them, or structured. We can use structured data. We can define them with a few simple features. In fact, a lot of early computational phenotyping work, a lot like the regression model. When you line up a few variables, weight them on the data and the training data, and you get your prediction. So this is a lot of phenotyping algorithms, computed phenotypes basically are built up. But when we step into real world of complex phenotypes, like the long COVID, as I mentioned, or ME/CSF, or autoimmune disorder, that simple model falls apart. Now, these conditions involve dozens, if not hundreds of parameters, and they don't behave in the same straight line. Their features interact, shift, and can vary across individuals. And that's exactly where precision phenotyping becomes critical. Instead of squeezing everything into one size fits all model, we dynamically adjust model uncertainty and pull from multiple data sources to build truly patient-specific phenotype. So in this parameters bar, it's not just about adding more features, it's about capturing the real messy complexity of disease biology, and finally reflecting that complexity in our data. If you really want to understand the value of precision phenotyping, think about what's happening right now in artificial intelligence. This is an analogy to AI, especially with LLMs. In AI, there are small models with fewer parameters right now that you have probably interacted with. They are increasing in complexity over time. Simple ones can handle basic tasks. They're fast and simple and good enough. But the minute you ask tougher questions, for example, you need context, nuance, or depth, you need models with a lot more parameters to capture the complexity. The exact same principle basically applies here in clinical phenotyping. For simple, well-defined conditions, a low-parameter model might work just fine, a typical computed phenotype. But for more complex heterogeneous disease, we need possibly high parameter, but most importantly, adaptive models that can handle the full diversity of how disease actually looks in patients. And I'm talking about ensemble of models or composite type models. That's what precision phenotyping does. It basically adapts. It lets the same clinical definition express differently depending on the individual patient's unique data, while holding true to the common computational anchor. Just like a good AI can answer the same question differently, depending on who is asking, precision phenotyping lets us meet the patients where they are. Not very rigid model says they should be. Now the journey to precision phenotyping, just an overflow, it's very similar to the computational phenotyping, but with the difference that there are several. Imagine there is, instead of one regression models, there's multiple regression models with varying complexity. We start with digitizing the patient's data. We turn each person into a digital twin built from their electronic health records data. Then we apply computational phenotyping, and we go further from just simple yes or no answer. The key here is that precision phenotyping doesn't rely on one single model. Instead, we build a composite of models each tuned to different features, parameters, or patient subgroups, which allows phenotype definition to adapt to the reality of patients. Okay. So I want to describe this use case on long COVID. Let's talk about long COVID. Long COVID is really one of the most challenging conditions to define in modern medicine. Within the ENACT network, we've worked to implement a computable definition for long COVID, also known as PASS. So the definition, according to the World Health Organization for long COVID, is that it's a condition that emerges after a COVID infection, persists for at least 2 months, and here's the tricky part, cannot be explained by anything else. In other words, it's basically diagnosis of exclusion. We know it not by what we find, but by what we rule out. Then in 2024, National Academies of Science, Engineering, and Medicine took it a step further. They emphasized that long COVID should also be classified as an infection-associated chronic condition, basically strengthening the tie or the link back to the original viral insult, but also acknowledging its long-term systemic effects. So to turn these definitions into action, we leaned on 2 key tools. One of them was the ENACT ontology, and the other one was a sequential pattern mining algorithm we had developed in the past. These tools basically gave us a flexible data-driven phenotype aligned with both the WHO, the National Academies frameworks, and ready to deploy across the ENACT networks, distributed EHR partners. So in 2024, we made our first big push to implement the long COVID precision phenotyping algorithm across ENACT. At the heart, the model was a temporal attention mechanism drawn from the MGB dataset designed to prioritize clinical patterns that mattered most after COVID. We basically packaged the entire thing into a Dockerized environment for easy and reproducible deployment. And we even brought teams to Boston for a hands-on workshop, walking through the setup live. And this is the key, we hit a wall. It was compute power. Most sites just didn't have the infrastructure needed to run the models at full scale. Even though the execution kind of fell short, it was a critical learning moment, revealing what we really need to build true scalable distributed precision phenotyping algorithms across network. Because if we want to unlock the full potential of precision phenotyping, I believe that it's not just about the models, it's about building the infrastructure to power them. Here is a broad description of how the model basically performs. So imagine you have a patient and you put all of their data on the x-axis, which is time. Then there is all of these potential EHR records in X's, and then there is COVID infection in C, and then there is potential long COVID in J. We basically applied our sequencing algorithms and then implemented the WHO and National Academies definition using the sequencing algorithm, saying that, okay, there has to be a sequence of that J that happened after COVID, and then it has to be associated with COVID because we computed the correlation and the distance between the 2 elements of the sequence, and then it has to persist, so it's translatable into these sequential patterns, and then it cannot be explained with anything else. That means that nothing in the past could explain that J based on the correlations that we came up with. So I can explain more about this algorithm, and there is details both online and in the manuscript in the article, but I can get back to this if there is questions. But in general, what happens is that running this algorithm resulted in what we call precision path research cohort, or P2RC. It's very individualized on each patient. So in each individual patient, a symptom or a diagnosis could become, for an individual patient, or a diagnosis can become long COVID. Same diagnosis for another patient may not be long COVID. An example is, shortness of breath after COVID could be long COVID for a patient that didn't have anything in the past that explains that. But in a patient that had asthma before, it's probably not long COVID, unless it's an exacerbation of shortness of breath. So this is how implementation of the algorithm allows flexibility to identify individualized incidents of long COVID. And as you can see in this diagram, for each patient, for each incidence of long COVID, you know which COVID infection it's associated with, what is the date of that infection, what is the broader group of that long COVID problem, and what is the date, and then it translates to an ICD code. All of these rows go into this precision path research cohort. So this precision research cohort, P2RC, has a lot of benefits. So you can see that we have a lot of detailed information about a lot of, how long COVID actually manifests across body organs. One of the biggest benefits, though, we've seen with P2RC is how much it improves accuracy and representativeness compared to if you were to apply a standard, say, long COVID diagnosis code, which is U09.9, to identify a cohort. So we basically identified over 24,000 patients within the MGB population with long COVID, with potential long COVID. This is compared to if you wanted to apply U09.9, you would only get about 6,000. That means that we are getting closer to the true national prevalence estimate. We are not underestimating. We might be overestimating slightly, and that's because of the inaccuracies in the EHR data. But at least we know that we are not grossly underestimating its prevalence. But also, it's not only more realistic prevalence estimates, it's also a more representative group across race, gender, and ethnicity. And that matters because doesn't just boost our number, it reduces bias, and it gives us a more accurate picture of who's truly affected by long COVID. With this precision cohort, we can run in-depth analysis on clinical genetics, demographic differences in risk, because we have both a large sample size and precise individual level data. And we have run a lot of these type of studies. In short, in precision phenotyping, what you get is better science, bigger insights, and a future where complex conditions like long COVID are studied with the scale and accuracy they deserve. So in conclusion, here's an overview of what we've discussed. Traditional phenotyping methods, while useful, are often too simple to capture messy real-world variability we see in conditions like long COVID or autoimmune disease or complex phenotypes. Our work with long COVID has shown just how powerful precision phenotyping can be. We curated a highly specific, richly annotated cohort. Remember that anosmia problem, like if you had an anosmia clinical trial, we have pinpointed about 120 distinct cases of potential long COVID anosmia, for example. It's incredibly hard to find that cohort in a clinical trial, and we're collaborating with investigators across MGB who are working on clinical studies on long COVID anosmia. And it wasn't just theory, it made a real clinical impact. For example, at one other implementation, we have found out that applying our precision path phenotyping has resulted in a jump from under 1.2 patients per week to 3 patients per week in engagement from patients in filling out these surveys, long COVID related. Okay, so this is my final slide for now, and we can go back to questions. So when we first started implementing precision PASC phenotyping across ENACT, we ran into some real barriers. First, as I mentioned, there was computational power. Bottom line is that these are high parameter models. They need more infrastructure than many local sites currently have, or infrastructure that are accessible for a study that is beyond the scope, or applying algorithms that could be beyond the scope of straightforward algorithmic work. Second, there is financial incentives that weren't in place. And this is the reality. We didn't have anything in our grant to support a local implementation. Without a direct return, it's hard to prioritize that kind of investment. But even with these barriers, there's a tremendous opportunity. I think the ENACT network already has strong distributed infrastructure. Not only the data models, the loyalty algorithms, all of these can be easily utilized to run our algorithms. And we've built software frameworks to make it easier to roll out these algorithms across different sites. Right now, we are leveraging what we've developed at MGB. So we offer sites a choice of either reuse our temporal model outputs or rerun the full pipelines locally. Even better is that sites can benchmark their results against our MGB cohort. So any other site that runs, they'll get their cohort, and then they can basically P2RC cohorts comparison between MGB and the other side. So recently we've been doing some research on clinical trials who are actively recruiting for PASC-related studies. And it turns out that there are 17 PASC-related clinical trials actively recruiting in academic medical centers who also participate in ENACT. So we think that this is a real chance to try to re-energize and reinvest in this work, not just for better algorithm, but for better, faster clinical research. We are thinking about ways that we can use the momentum and the need in those clinical studies and match them with the ENACT infrastructure and say, to increase energy to implement these algorithms. Because at the end of the day, I think scale and precision phenotyping isn't basically a technical challenge. It's a commitment to reshaping how we do clinical research. I just want to thank, here are the links. There is very detailed instruction on how to apply the algorithm, whether you are within the ENACT network or not. And then here is the link to the article. I just wanted to thank our funding source and our collaborators and the CLAI team. Right.
Okay. Thank you, Hossein, for that great introduction to, I would say this is distributed computing. So as probably everyone knows, in ENACT, we can do simple counts-based analysis where you're using the Shrine network and the Shrine platform to obtain counts, and you can do a certain amount of research just by doing that. And at the other end, we have enclaves where we move the data, and you can do standard kinds of analysis. So what Hossein presented today is distributed computing, where the computing happens locally and the data doesn't move, but you're doing more sophisticated modeling and computing compared to just getting counts. I just want to mention that there's going to be an I2B2 symposium on June 9th and 10th in Boston, and there's going to be more that Hossein will be presenting there in the workshop on June 10th. Okay, so we'll open this up for questions, and you can enter either the questions in chat, and I think we can have you just also just talk into the microphone. So yeah, let's see whether there are any questions which are there. Okay, well, waiting for any of the audience members to have questions. So I got, I think, a couple of questions. So one question, Hossein, is in terms of just running the models, which I guess are just these patterns that you have learned at in MGB, is that less computationally intensive if you provide it to another site versus them running the whole algorithm to learn the patterns at their site's data?
Yes, it would be a lot less computationally intensive. One of the things we did was that we basically computed sequences of all of the records in both cases and controls, which controls were patients who did not have any evidence of a COVID infection or probable infection based on the ENACT definition, or what is applied in ENACT Shrine. You can basically easily query that. So we computed all of these sequential relationships with different time buckets. So there was, for example, cough could be associated with flu within 1 week, and there's potentially a high association, but cough with flu and 1 year, they should not be really associated unless there is something wrong, right? The person is still coughing. So we computed all of these temporally and used that as the attention mechanism. Now, this requires a lot more compute power. Mm-hmm. That if this was to be reproduced, this attention mechanism in other sites, it requires more compute. But it's not necessary, in my opinion. I don't think that utilization patterns should actually impact that those temporal associations that much. I think it should still be something similar, although with varying levels of association, which could still hold. So the first step would be, the easiest way would be only identify potential cases and run the algorithm on them, which is relatively straightforward.
Okay. Yep. Thank you. I think Doug Bell, you have a question?
Yeah, I was going to ask. I just wanted to clarify. I think that you're not using notes at all, right? This is just right, the data, the structured data that's there in ENACT right now, right? Okay. And using machine learning on that. And I also wanted to code was up so briefly. I didn't get a chance. Could you go back to that slide with the QR code? Yeah, thanks. All right, got it. Yeah, I definitely want to take a closer look at what you guys did. Great, thanks. I got it.
Yes, and UCLA was one of the sites, as you know, that we tried to work on implementing the algorithm on.
Yeah, we're glad to participate. So yeah, it was great to see the result. And I guess I didn't fully understand the key results were in that, as long as I still have the floor, the key results were in that slide a few back. I didn't completely understand what was going on there. I guess I would still need to read the article. Yeah, this one made sense more or less. I like the way you showed this, but the next one,
Oh, the next one, yes.
I
So
wasn't sure what was going on here. The inner
yeah,
circle,
so
and the outer circle.
what happens is that you see at the end of this step, we can actually map back what is the actual ICD code for this long COVID. And
Okay.
when you have the ICD codes, then what we did is that we just basically mapped them to body organs, and then to a group of different groupings of body organs. And you see some of them here, like how many of them were systemic, and in systemic, what are the distribution of all these problems that we have.
So just to go through this more slowly, somebody else, please interrupt if you want to do something else. But so there's 10,000 patients who had systemic symptoms, I guess, in this past cohort.
Yes, this is 10,000 incidences of systemic PASC.
Incidence of the symptom or incidence
Yes,
of
the symptom. Yes,
symptom,
yes,
right.
yes.
So each patient might have multiple.
Yes, that's true.
Okay, and what's the inner circle versus the outer? The outer circle is.
So there is the signs and symptoms. I think SNS is signs and symptoms, and then there's like sleep disorders, malaise and fatigue. There is.
And these are all past symptoms that were associated with the original past diagnosis, right?
Exactly.
Or the original COVID diagnosis.
Yes.
Great. And then, sorry, what's the outer circle?
The outer circle. So there is, as I said, there is different levels of. We did 3 levels. So one was organ, so systemic, GI, respiratory, and then there is this higher level, which is higher grouping, and then there is in signs and symptoms, we went deeper into like what is the actual signs and symptoms. This is like dizziness, weight gain, weight loss, pain, and you can.
So the people if that first one is edema, right? 13%.
Yes.
So you're saying those people had both sleep disorder and edema? Is that what that means?
So 13% of this 10,000.
I see.
No, not the 10,000 of the
87%.
Yes.
Got it.
Yeah.
I see.
Yes, exactly. So 67%.
Also had edema.
Yes.
Got it. Okay.
Yeah.
So it's just showing, of course, yeah. Okay. I guess I get that. Yeah. Okay. Wow. Quite a variety of symptoms, obviously. Huge variety.
And there's another one. There's another graph in the paper. I didn't put them up. So we basically broke it down across, I think, all the organ systems.
I see. So for cardiovascular sleep disorder, I don't see a label on that. That 44% or what? Sorry, I'm just obsessing though. No, it's okay.
Yeah. Well, yeah. You can. I mean, the full picture is also in the article, and we have, I think, the numbers in the appendix. Yeah, actual.
Oh, okay, great.
Great. There are a couple of questions in the chat. So one is from Fred Fan. The question is, can sequence mining that you're using be used for other diseases than PASC, especially for the ACT model, the data model that we're using?
Yes, I think so. This is one way of using the sequence mining. And so the reality was that we were thinking about, okay, how do you actually implement the definition? Like, how do you implement a computational definition for diagnosis of exclusion? And what we came up with additional criteria, which is, it has to be persistent, it has to be, after COVID, it has to be associated with COVID. So this was actually a new use case for the sequence mining algorithm that we had. We have used the sequence mining algorithm for a standard computational phenotyping in the past. But this is one way of just, I think, simplifying or implementing a complex query by turning individual features into sequence of features. We haven't basically shown how faster it will be, but we could basically ask a person like Michelle or Darren to see, like, how would you write a SQL query to do this if you didn't have the sequences, right? So we created a high performance algorithm to mine these sequences, and then we thought it's easier to implement with just 3 lines of query to get what we want from the sequences of things. So I think when you're dealing with these temporal definitions, yes, they can be applied for other diseases. And they can also be applied as features in machine learning, which is another way that they can be applied to identify or model diseases.
So I guess one follow-up question is that can this algorithm be run on an I2B2 database? Or
yes.
do we have to? Okay, so this was actually, you had actually developed it so that we could
exactly. So
run it at the different sites directly on the I2B2 database.
Yes. And in the I2B2, in the workshop that we have during the I2B2 symposium, we are going to basically explain how this algorithm runs off the I2B2 database and our I2B2 data model. In fact, it is inspired by the I2B2 star schema. There is a long, we use the long fact table to basically to extract these sequences. It directly uses the fact table, and then you basically map it with the ontology.
Okay. This is a second question. This is from Mark Abajian. So in terms of the computational power issues, how much power do you need? Say, for example, when you ran this algorithm at MGB?
Well, the main bottleneck when we had in other sites was that when they were trying to run it on a machine with 16 gigabytes of memory. So I think 96 gigabytes of memory would have worked. But it turns out that not many, it wasn't available. Or if it was available, it was in a server in which they weren't able to actually install the Docker environment. So I think if we could basically turn it into an edge, computing problem and install the entire thing in a like a edge compute device with, say, 96 gigabytes of memory, it should generally work. But it also depends on how many patients we have. So at MGB, we applied this to about 400,000 patients to begin with. And 400,000, we had higher memory. We had a machine with about 256, but if you only want to apply it on the cases, it's usually a smaller cohort size. So I believe that 96 gigabytes of memory should work.
Okay. Let's see. Any other questions? Okay, well, we'll see whether any other questions pop up. So one other question I had was, can this be done in a distributed fashion where you learn the patterns from several sites without bringing all the data together?
Absolutely. Yes. So,
Okay.
so what is really so there is a couple of challenges. One is the compute challenge, as we discussed.
Yeah.
So if that's resolved, so technically, all of these sequences can be mined, all of the temporal association can be computed. Now, when you want to basically identify what excludes the other thing, that becomes where the weights may need to be localized. And this is a hypothesis that we haven't tested yet because nobody else has run the algorithm. If other sites actually run the algorithm, we will be able to actually compare the association matrices that are computed between the two different sites and say how similar they are or how different they are. If they are similar, it's just easiest, right? Because you can use the weights that we got from MGB and apply them to your site. But if they're not similar, a key challenge will emerge, and that would be a validation set, which requires chart reviews to fine-tune your algorithm. That's a bottleneck, or that would be a bottleneck. But again, we still don't know if the weights will be different. Honestly, I have no reason to believe that the weights should be significantly different.
Okay. Yeah, that's helpful to know because some models you have to iteratively train them, and if you're doing it at multiple sites in a distributed way, you need a more complicated setup by which the parameters go back and forth.
Yes.
From a central place to the local sites. But this one, that way is much more advantageous that it could potentially just work out of the box at a new site with the weights that you learned at a different site.
Yes. So at each site, if the full run is done, it give you an attention mechanism. Basically, it's a non-PHI shareable data. We've shared it on our GitHub for what the associations that come out of MGB. So first step would be the question would be, are they different, between sites? And we can easily test them. It's very easy to test them to see variability between these things, the patterns that we see. And then the next would be if they're different, how do you weight individual site algorithm? But it's, those are all next step questions that maybe we should try to address in the renewal of the grant that we have. We're entering year 4 and 5, and the focus in these years is to actually try to answer these questions. That's why we are emphasizing on finding ways to energize implementation at other sites. One of the ways, I think, is this possibilities of providing patients for the clinical studies that are running. I know Doc, for example, at UCLA, there's clinical studies on PASS. They're actively recruiting. So this is how we actually found our collaborators at MGB. They are recruiting patients, but they're not able to, right? So how are they going to find long COVID anosmia patients? Or, for example, that's one case. So we are hoping that if we can connect them, identify those investigators, and then try to connect them with the local ENACT PI, for example, the PI for the studies at UCLA with Doug, and then say there is now more motivation or interest and potential resources to put in now to implement this algorithm and create a similar cohort at each individual site.
Yeah. I think one more question, which is around, so among the features that you use, do you use any features which might be highly specific to a site, like, say, a particular specialty clinic, where the person might have gone? And those are very, very different. People go to different specialty clinics for long COVID, for example.
We did not limit any feature.
Okay.
So it's possible that we get more, more of some codes in some institutions versus other institutions, or less of some code. Still, I'm not sure if that's going to impact the temporal associations. I think still the association between cough and flu should not be higher and lower, right? Or maybe they are. I cannot think of any reason they might be. Unless that is not impacted, I think it's still fine.
It should generalize. Okay. But yeah, this is very interesting. We need to just run it at other sites and get some results.
I look forward to that. And especially the I2B2 symposium will try to again explain how this is run. Very hands-on workshop.
Okay. Let's see. Can you go to the last slide?
Last slide?
Yeah.
This.
No, after this.
This one?
No, after this. Or after this.
Oh, here. Okay.
Yeah, this, I just want to, I think if there are no more questions, I would like to thank Hossein for his great presentation of this talk. And just to remind everyone that this will be an I2B2 symposium on the 9th and 10th of June. And on 10th, Hossein will be continuing talking about this project and how to implement it at other ENACT sites. And then the next grand rounds for ENACT, we'll have that on Monday, the May 19th at 3 p.m. So I think with that, thanks for attending and have a good week.